sporadic newborn screening pilots using cord blood for congenital hypothyroidism. So this happens in one of our provinces, but then the coverage is very low, at about 3.8%. Secondly, there's also more comprehensive newborn screening being offered in South Africa. This is offered by the National Metabolic Platform, which is at the Northwest University. So basically, they supply this as a fee-for-service basis for the private health sector for 20 conditions, which include inborn errors of metabolism, as well as some endocrine disorders. Okay, as you can imagine, the coverage is also very low, less than 0.5% of South African newborns that undergoes this service. So these are the ones that can afford. So these services provided by the tandem mass spectrometry, which is actually now becoming the most preferred and established method for newborn screening, because you can actually screen up to 50 conditions with just one dried blood spot. So there have been several publications in South Africa whereby we sort of know which conditions will be targeted for screening. Okay, so these conditions include congenital hypothyroidism, congenital adrenal hyperplasia due to 21 hydroxylase deficiency, cystic fibrosis, GARD deficiency, galactosemia, organic acidemia such as propionic acidemia, as well as glutaric aciduria type 1. So we also had this 2-day meeting in 2023, which was organized by the IFCC Task Force on Newborn Screening, as well as Rare Disease South Africa. So the whole point of this meeting was to how do we take newborn screening forward in South Africa. Okay, so we're looking mainly at the biochemical newborn screening. That's why we had 4 clinical pathologists, including myself, being represented in this meeting. We also had pediatricians, we also have geneticists, we also have a representative from the Department of Health, as well as a representative from the World Health Organization. Okay, so the content of this meeting resulted in a publication, which you can see there. So, but the recommendation for this meeting was that we establish a national advisory panel for biochemical newborn screening in South Africa, and then we develop funding and implementation of a comprehensive or a pilot project for biochemical newborn screening in the 2 provinces, which include my province, Limpopo, as well as the Western Cape. And then we present the findings of this project to the National Department of Health to propose an action plan to implement newborn screening, at least for one condition, congenital hypothyroidism. So in the interim, we also advocate that there should be some hearing, visual assessment, congenital heart disease screening, as well as comprehensive physical examination prior to discharge in the absence of universal newborn screening. I'm going to zoom in the rest of Southern Africa. So now what we know that sickle cell disease is a big problem in sub-Saharan Africa. It's got very, very, very high prevalence, whereby 70 to 75% of the babies born with sickle cell disease come from sub-Saharan Africa. And actually one of the countries coming from our region, Tanzania, has the 4th highest prevalence of sickle cell disease in the world. And unfortunately, with this current state of affairs, there is no universal newborn screening program. So instead, what we have a pilot project being done in some of the countries, as well as surveillance studies on sickle cell traits, as well as sickle cell disease. But there's no universal newborn screening program to detect this condition early. So other things that we've observed in our region is that there's decreased infectious disease burden. Okay, so basically there's decreased mortality due to communicable diseases because of the antiretroviral drugs that result in a prevention of mother-to-child transmission, as well as rollout of immunization and improved maternity care. So now we're seeing that there's an increasing contribution of non-communicable disease to infant morbidity and mortality, whereby there's increased proportion of congenital disorders-related deaths. Okay, so really, is what we should be really be focusing on these non-communicable diseases and congenital disorders, And one way of doing this, it is through several publications in Southern Africa that talks about newborn screening. So you can see one from Tanzania, one from Angola, there's one from Zambia, as well as a cost-effective analysis, and one from Malawi. So there's been several publications with regards to sickle cell disease. So what are the lessons learned? The lessons learned is that newborn screening for sickle cell disease has been shown to be cost-effective, okay, especially with those countries where the prevalence is quite high, and it's demonstrated by this publication there. And also seen that HIV and immunization programs have been successful. So if you can integrate or partner with these programs, you can also get newborn screening somewhere, particularly because, like for example, the HIV PCR at 6 weeks is done on a dry blood spot, okay, which can also include other conditions to screen for on the same DBS sample. Academic institutions like universities, they can provide training and support policy, which can result in protocol development for some pilot projects, which can result in implementation of newborn screening initiatives. In our region, we also have unique, diverse social and cultural aspects. For example, traditional medical service still exists within our community, with some births done actually carried out by traditional midwives, so to speak. So this cultural aspect can also lead to stigma of these congenital disorders, which also need some careful considerations. So what's the way forward towards implementation? So I think we really need local champions that are equipped with technical knowledge and experience. And these local champions must be supported by the ministries of health as well as policymakers. And then we need to establish centers of care. So centers of care will provide comprehensive care for conditions like sickle cell disease. We are also in the process of trying to establish a center of excellence for rare diseases in South Africa. We also need public engagement as well as advocacy to garner community support, and then we really need to partner with those successful newborn screening initiatives and how they're going to be sustained, so that we can learn from them, so that we can also get somewhere to go to implementing sustainable newborn screening initiatives in Southern Africa. So yeah, so comprehensive newborn screening programs, so they are largely dependent on these key factors. For example, the consensus legislative framework to be able to implement newborn screening, financial costs, whether it's due to the government or some non-profit organizations, and some prevalence studies to be able to provide the data on the prevalence of disease, so that we can convince locally, but not only treatment, we just need availability of resources. For example, the equipment, the reagents, the healthcare workers that will be involved in treating these conditions. And then the initiative, so basically it needs to be feasible and practical for the existing health system, so that it become sustainable. There's also cost-effective ways of conducting newborn screening. For example, through a point of care screening, for example, the pulse oximeter for critical congenital heart defects, or even devices for hearing tests, which can also be done for newborn hearing screening. Similarly, there's for Africa, we've got this paper chromatography as well as specific antibody lateral flow assays, which can also be used for screening for sickle cell disease. So step forward. So we really need some advocacy work is required for newborn screening, as well as to raise awareness, like we're doing now with this webinar. So in South Africa, we are working on a comprehensive newborn screening pilot at 6 hours. So this is basically to address the issue of early discharge, since our babies get discharged so early. So it means that we really need to get the data with appropriate cutoff points to allow newborn screening 6 hours after birth. We are also working on the health economics of congenital hypothyroidism newborn screening, which will be a pilot project in South Africa as well. So all of this, we really need to get the government and health policymakers being involved as well to endorse newborn screening to take it forward in our region. And also look at the possibility of starting small, okay, even just starting with the newborn screening for high-risk patients. For those ones that already know they are either a carrier or they are trait of sickle cell disease, for example, or they are known with other congenital disorders. You can just start screening those newborns because of the high risk. I'm also involved in this the FCC Newborn Screening Committee, whereby we're trying to encourage as many African countries as possible to develop a policy on newborn screening that is implementable and sustainable. Okay, so our chairperson is from Nigeria, Prof. Akina. We also have Prof. Aneto. In South Africa, I'm representing South Africa as a secretary. We also have Prof. Erasmus, and then from Kenya we have Prof. Amayo as well as Prof. Hakima, also from Morocco. So currently we're working on editorial to publish on newborn screening in Africa, which will be followed by opinion paper. And we're just hoping that this publication can also be able to raise awareness on the need for newborn screening in Africa. So we'll also be distributing a survey soon for the FCC African so that we can know the current status of newborn screening in the various countries, so that we can have as many countries represented in the committee as well. So I just want to speak about this congenital hypothyroidism, because I think it's a condition that is also being neglected in Africa, but is actually one of the most screened for in the rest of the world in terms of it being cost effective. So this picture comes from the Philippines. So they use this picture to raise awareness on congenital hypothyroidism. So this picture actually represents two siblings. Both have congenital hypothyroidism. Okay, so the difference here is that the lady or the female had newborn screening, so therefore it was detected early, and then complications were averted. But in this patient, who's actually, when the picture was taken, he's actually 14 years, okay, and he's actually 8 years. Later on, was 12 years. And by this time, the complications have set in. As you can see, it's severely stunted, big bang, microcephaly, and global neurodevelopmental delay. So you can see that it's actually is unable to mobilize. It's actually wheelchair bound. Okay, so a few years later, the female went to university and then also became an engineer, while he stayed with the neurodevelopmental complications, and then which can be a burden to the family. So this is one of those things where the success story that needs to be preached, that congenital hypothyroidism is one of those things that should also be screened for to avoid these late complications. In conclusion, I think we should be really advocating for countries to develop a newborn screen policy that is locally appropriate and acceptable, and integrating with immunization in HIV screening programs, because largely they've been successful. So maybe this can also contribute to successes of newborn screening. So because we don't have newborn screening that is universal, so thorough postnatal examination is very important, so that we can also try to diagnose these patients early. And then there's also alternative cost-effective methods with, for example, the point of care for sickle cell disease. Pilot projects can also go somewhere, but they require funding, whether from the government or from other organizations. And at the end of the day, you want to this lifelong advocacy so that we prevent this intellectual disability and decreasing the burden of childhood mortality as well as morbidity. So in the high-income countries, they're actually looking at the future now, where they perform this genomic newborn screening sequencing method, where they can actually get a diagnosis of rare disease within a day. Okay, so in our setting, we still use genomic as a second-tier testing, but you also be looking at it in the future to be able to diagnose as many congenital disorders as possible through their whole exome sequencing and whole genome sequencing. So these are the references. So yeah, this webinar is based is done in celebration of the International Newborn Screening Day, which I've also learned that it was referred to as the International Female Kidney Day, and the same day. And then in the month of June as well, it was also the World Sickle Cell Day awareness as well. So these are conditions that we should really be looking out for with regard to newborn screening in our city. And thank you so much for your attention.
Thank you so much, Dr. Tumelo. We are running out of time, and so we will entertain questions at the end of this webinar. And we now will invite Professor John Aneto, who is based at the University of Ibadan in the Department of Chemical Pathology, to make the next presentation. And please, I think since we are running out of time, if it's possible to keep it to 20 minutes. So over to you, Prof. John Aneto.
Good morning. Good morning, everyone. Can you hear me?
Yes,
morning, Aneto, we are hearing you.
We are hearing you.
Good morning. Can you see my slides yet?
No, we can't see your slides at the moment. Just try and share them. Can you please unmute yourself, John? I think we are having some connectivity issues. Let's just be patient.
I think he has dropped out. He's trying to rejoin. So maybe in the meantime, you may consider going to the next whilst he's sorting his connection.
Okay. Daniel, can you please link up? Hello, Daniel.
Yes, Prof. I can hear you.
Okay. If you can please make your presentation. Okay, thank you very much. So we will go on to the next presentation, which is on newborn screening journey, overcoming challenges and celebrating milestones. Now, Dr. Daniel Miner is well known to me. He is based at the Aga Khan Hospital in the Department of Chemical Pathology, and he is involved in a newborn screening program that is being organized in Kenya, and he has recently joined the AFCC Committee on Newborn Screening. So over to you, Daniel. We look forward to your presentation.
Thank you, Prof, for that welcome and introduction. So newborn screening for us is pretty new. It's something that we are still working on. We are not yet there, but I'll share some of the steps we've taken and how we have reached so far. As introduced, I work at the Aga Khan University Hospital, which is based in Nairobi, Kenya. And the reason why at this hospital, we decided to concentrate on newborn screening. It's because we are doing everything else regarding fetal well-being. That is, we are doing the maternal biochemical screening. We are doing the imaging just to see that the fetal development is okay, identifying some of the congenital disorders. But there isn't much focus on screening the neonates. So I mean, we saw that as a gap in our service, hence the focus on newborn. So talking about the background in the country, so in Kenya, we have both what you call the national and the county government. That's the structure that we have. But none of these two levels of government offer any kind of NBS program. And this also extends also to the public and private laboratories. So far, none of them perform what you'd actually call a complex or a comprehensive NBS in-house. So as far as the clinical practice goes, the practice is varied. It's both physician and parent dependent. So there is demand for newborn screening from parents that have been exposed to other countries with NBS program. And normally this would be the expatriates based here in Nairobi that are used to NBS programs back at home. So sometimes they do drive the demand for newborn screening in our facilities. So despite the fact that we don't have any national data, we don't have any program, there have been attempts to basically just look at what could be some of the inborn errors of metabolism that you might have around. So I'll refer you to this study that was done at Kenyatta National Hospital that looked at children 0 to 18 years. The sample size was 78. And they zeroed in on patients that had suspected IEMs, either because of a history suggestive of IEM, a family history, or the physical exam, or sometimes they had genetic studies. So from that chart, I mean, it is clear that despite us not testing for these conditions, that these conditions do exist in our newborns. And that was the prevalence for the IEMs in that study. So, so this gives us the information that probably there's a lot that we are actually missing as a country by not having a newborn screening program. So again, this was a one facility study looking at congenital hypothyroidism in a children's hospital, again based here in Nairobi. And they were actually able to demonstrate a high yield of congenital hypothyroidism among the infants. These were infants from 0 to about 2 years. With that incidence of 14 per 1,000, which is much, much higher than the global incidence. But more concerning is that 12 or about 60, more than half of these children with confirmed congenital hypothyroidism, 60% actually had poor developmental outcomes. So in as much as we are concentrating on facilities, just based on this study alone in Nairobi, then one can actually extrapolate and say that probably then there's a lot more happening within the Kenyan Republic that is actually being missed. So there's need to actually have some kind of universal screening that is countrywide and not just facility led. Again, we know that the focus has actually been on infectious diseases, but what we've seen is that the infant mortality rate has steadily been declining, and this is because of the expanded immunization program that has actually been able to control most of those infectious diseases. But if you're to maintain this downward trend and improve the overall health of children, there is need to focus on non-infectious diseases as well. And I think that's where newborn screening would play an important role to actually maintain that downward trend. So we've had the plan to introduce newborn screening at our facility since 2022. So I've had interactions with pediatrician colleagues. We have also had discussions with several or 2 vendors. So the first one was not very successful. But since 2024, we have identified a vendor and we are actually awaiting the delivery of the equipment. So for us, we'll start small. We just start with about four conditions. Of course, congenital hypothyroidism among them, as you've seen from the previous study findings. And then, again, as in the case of South Africa, we'll take baby steps and then keep on expanding the service as we get more buy-in and as we get more experience on that. So we are not alone in this journey. We have a sister hospital in Karachi that has been running this program for quite some time, and they're able to actually screen about 2,000 newborns every month. So they've been assisting us in terms of sharing their experience, sharing some of their documents with us. So hopefully we'll also be able to take off very soon. So we're in the process now of forming a committee. We've already formed that committee, the NBS committee, that comprises the laboratory personnel, neonatologists, and obstetrician. So we are currently developing the SOPs. We have already registered for the EQA program with the CDC. As you're aware that the CDC does run a PT program for newborn screening. So we expect that the equipment delivery will happen this month. And then in the next 2 months, we shall do the installation training and method verification. We already have a package in place. That is a feasibility study. We performed a feasibility study and basically then came up with that package that we believe will be sustainable. We have also joined several organizations, the ISNS, the Partnership with African Research and Innovative Initiative for Sickle Cell Education, because we also want to, among our conditions that we'll be screening for, one of them will also be sickle cell, because sickle cell for us is of public health importance. We are in that belt, the sickle cell belt. So moving forward, we plan to sensitize the clinicians and public on the benefits of NBS through CMEs, conference presentations, and targeted talks. So we've already drawn up a program. So we'll be having one of the CMEs tomorrow, basically on NBS. And then, as I mentioned, we've started with the baby steps, but we want to actually enhance the scope, probably then have more conditions being screened for. Also the techniques, as we said, the issue about the mass spec. Right now, you just start with the biochemical assays. And then in collaboration with some professional societies like the Kenya Association of Pediatrics, we plan to lobby for recognition and inclusion of NBS in the national and private insurance schemes, so that the funding could also, or reimbursements could also come from the national schemes as well as the private insurance schemes. And as I mentioned again, this should not just be left at the facility. I think we need to have a nationwide or a county-wide NBS program. So part of that would also be lobbying for political will to support NBS and allocated resources at the national and county levels. So we are coming up with some pamphlets, especially for patient education, targeting the parents, so that we can actually get buy-in from them. So some of the challenges that we are grappling with, first would be the assay verification, including the population-specific cutoffs in our population. As I said, we don't have any existing data so far, so it will be a first for us. The issue about confirmatory testing, as I said, we still don't have the lab facilities within the country that can actually do some of these. So that would be an expense for us, having to outsource these tests to labs outside for confirmatory testing. Of course, to start with, because this is a one facility, we also worried about reagents utilization. So some of or what we've actually been able to negotiate. So those pack sizes sometimes might be quite out for one facility, but I believe if you have these as a regional or as a national scope, we can better make use of those reagents. Limited scope, limited resources, clinical validation. So some of these, or most of these conditions, of course, will also be familial. So the issue about genetic counseling is something that we are thinking about alongside other genetic disorders apparent in our population. So that is something that we are working on from a facility based. The issue about follow-up care, because it's one thing to screen, but the more important thing is treatment as well as a follow-up care. So for us, we are lucky that we have neonatologists here. We can be able to follow up and treat the conditions that we'll be screening for. But that, of course, also comes with some expenses. And then, of course, there's lack of awareness on the importance of NBS, both, among the healthcare workers, as well as in the policy, among the policy makers. And of course, resources are always a challenge anywhere. So in short, that is what we've been able to actually come up with. And for us, it's still a journey, and we're still at the initial stages. So thank you. And back to you, Prof. Erasmus.
Thank you very much, Daniel. And I'm really very impressed with what you guys have started. And I was completely unaware that some studies have already been done at the Aga Khan Hospital. So just for our audience, the International Federation of Clinical Chemistry and Lab Medicine is one of the biggest organizations in the world. It has more than 105 member societies. And from Africa, we have approximately 15 member societies, and we are hoping that more societies can join in. And the Africa Federation of Clinical Chemistry is a regional federation of the International Federation of Clinical Chemistry. And since last year, newborn screening has become one of the focal areas of the IFCC. So I will now go on to the next speaker, who is Professor Okeshina from the University of Ilorin in Nigeria. And once he finishes, we will then go on to Prof. John Aneto, and hopefully everything has been sorted out, John. I know you are waiting to come in, but I had already contacted Prof. Okeshina to speak after the talk by Dr. Maina from Nairobi. So please be patient, John. So I will now invite Prof. Okeshina, who is the chair of the AFCC Committee on Newborn Screening. We established this committee at the beginning of the year, and you can see it's really going and powering ahead. So over to you, Prof. Okeshina.
Yeah, Prof, thank you very much, the coordinator. And I want to share, I was not allowed to share my slide because the host disabled. I want to share my screen, my presentation. So if somebody can allow me to do that, because I was clicking, it's telling me it's not allowed.
Please give us a second, sir.
Thank you, Sonia. So whilst we are waiting for Sonia to connect Prof. Okeshina, as I mentioned, the Africa Federation of Clinical Chemistry is taking a great interest in initiating newborn screening programs. And indeed, we are trying to coordinate it between the different countries of Africa. And you can see that we have Nigeria on board, we have Kenya on board, we also have hopefully Egypt coming in, as well as South Africa. So I just want to thank all the delegates who have joined in to listen to this. Oh, there is Prof. Okeshina with his presentation. Thank you very much, Sonia, for getting him on board. And so we would like to welcome Prof. Okeshina, just to also let you know that he is the past president of the Africa Federation of Clinical Chemistry, like myself. And he's also been a very active member of the Nigerian Society for Clinical Chemistry. So over to you, Prof. Okeshina.
Thank you very much. I know the time is far spent. Also, I want to appreciate everybody that has participated so far and those who are already online with us. This is a very important topic and issue for Africa and the world at large. Yeah, I disagree with Professor Erasmus that it's only last year. In fact, IFCC has been really concerned in the last 4 years on newborn screening. In fact, we partnered with WHO when I was liaison of person. So newborn screening has been a serious challenge for. And when we actually started quality assurance program, we started pari passu, that of newborn screening, with a committee in place, with Anector as member and Boyam as the chairman. But that committee is still having that challenge because of the technicalities involved with newborn screening. We have not been able to move forward on newborn screening in IFCC like we did for quality assurance and the rest of them. So this is a very important topic, and I will move forward and share my slide. It's not scrolling down. I don't know why. I will use okay, sorry, one point. Okay, so I've just introduced the topic because I know Chumelo and Daniel have given very important aspects of the whole issue, and I'm very impressed with what is happening in South Africa and in Kenya, and also even in Nigeria with the consortium in place. Those 3 countries seem to be coming up with something to overcome this challenge, which has been lingering on for more than 5 decades, because newborn screening is not only metabolic alone, like I've listed: endocrine disorder, hemoglobinopathy, which is sickle cell disease, immunodeficiencies, cystic fibrosis, hearing loss, and those are the ways they can just screen newborn for all these problems. But we are focusing on the metabolic aspect of it in this our discussion. So inborn error of metabolism is a heterogeneous group of disorders which result from reduced activity of enzymes, proteins, and transport molecules. Differs clinically, varieties of ways and present in various ways, and can have delayed growth, metabolic acidosis, and hypoglycemia. And they can be treated. Many of them can be treated if diagnosed early and prevent morbidity and mortality. The global incidence of inborn error metabolism is 1 in 10,000 live births, with about 140 million live births per year and several million children born with this inborn error problem. That's why it's very important. And inborn errors are known for high case fatality. And in low and medium income countries, mutation of diagnosis treatment capacity, inborn errors will lead to high infant mortality. In UK, screening has started since 1969, nearly 1960 when this microbiology man started the PUK screening and also congenital hypothyroidism. They started those two, and now it has expanded to 30 to 60 in UK. Also in America, they recently started this RUSP, which is Recommended Uniform Screening Program, because nationally they are trying to unify it, but it's not been possible for them. So every state has its own separate number of program the disease they screen for. Indeed, when Daniel was presenting, he was focusing too much on their center starting the program. But I think at the same time, you must see it as a legislative venture, because that's the only way you can drive this thing forward. You must see as a primary aim is to drag the government into it. Even if patient has to pay, the legislation that will make it binding on everybody that this particular disease, any child born must be given the chance to be screened. That should be the focus of any society. That's where it works. That's what has been in place. There must be a legislation that will drive the process of the. So in America now, they try to see each state will decide and make a legislative pronouncement on the particular disease to be included or to be removed from the screening program. And so now they have about 30 to 60 screening. They are screening, and with potentially there are 50 inborn error that can be done for inborn error. But when you talk of screening generally for newborn, they are doing about 30 to 60 in various states in the United States, and it varies from state to state. Sorry. So in Africa, apart from some North African countries, studies in inborn error is still very scarce. And I was impressed by Daniel that they've done some work. Also in South Africa, a lot was presented. I have also some references in Nigeria on what has been done, but it's still not what we're supposed to be having. So in the popular global review of birth prevalence and inborn error, Libya has its prevalence of 68.59 per 100,000 live births. Tunisia 39.10 per 100,000, while Egypt has about 18.5 in the particular reference that I had. Also, the breakdown of Libyan study shows that out of 19,938 children I'm coming. So these 27 amino acid disorders, 3 urea cycle, and I'm just trying to see the breakdown of what you have in that of Libya program, which was a bit comprehensive for Africa to see as an example that problem is already with us. These are the list of the various disorders that can be seen as important: amino acid, organic acid, urea, which are related to nitrogen, then carbohydrates, then fatty oxidation, lysosomal storage, energy defect, purine, bile acid problem, protein, trace elements, iron, vitamin, peroxima, and congenital disorder of glycosylation. Also, endocrine disorders are not captured there. Also, clinical presentation varies, depends on the type of disorder, and the outcome of the research is displayed there for that of Libya, and you can see the various diseases: homocystinemia, Hartnup disease, and these are amino acid problems. And for several time, let's just skip through them. So also still continue on clinical presentation of these various. this is what they find in that research, which was done in Namibia. And let's go further again to, in Egypt, the pilot study was on 25,776 early newborn screening were done, and 13 inborn errors of metabolism were actually investigated. 13 cases of inborn errors of metabolism that include 5 cases of phenylketonuria, 2 cases of isovaleric acidemia and methylmalonic acidemia. Also, 1 case of primary carnitine deficiency beta, so that was for Egypt. So we have pockets of research or things done, but we still need to do more to really confirm what is going on. And among the 3,900 subject cases of inborn error metabolism in pilot study, 235 cases were diagnosed as, okay, that's a repeat of what I've just gone through. Also, 3 cases of citrullinemia and 1 case of type 1 tyrosinemia, and the various diseases that were identified. Also, still in Egypt. Okay, sickle cell disease, which is another important disorder in among the Blacks in Africa. In Nigeria, there is 10 to 20%, so people are even saying more than that, maybe up to 30 to 60% of carriers in Nigeria now. There are many people are carriers of diseases. And again, it's also important that while we are looking for screening to pick the disease, we also need to pick the carriers, because for sickle cell, when carriers marry carrier, then the recessive problem can come up. So screening for carriers also should be also emphasized, not only detecting people when they have the problem. A study in Benin, Edo State, Nigeria, returned a prevalence of 2.3%, and the carrier state of 23%, which is in line with 10 to 20% that we listed above. Also, the pilot neonatal screening involving 4,116 units in DRC, 2,341 units, Burkina Faso, 943 units, and in Ghana, in Benin, 170,000, and in Ghana. So the frequency varies widely. We have 2.3, 1.8, 9.9% to 1, and respectively in these various countries. So these are the past countries in Africa that has been done. Also in KwaZulu-Natal, galactosemia was investigated, and the prevalence of 1 in 50,000 was, 1 in 11,000 was recorded, while in Zimbabwe, Mashonaland, 1 in 52,000 was recorded. Also in Port Harcourt in Nigeria, hypothyroidism was investigated, 1 was recorded. A similar study in Shaki in southwest Nigeria returned 1.5% for hypothyroidism. Also in Jos, there has been a report from there regarding hypothyroidism, and also in the province in South Africa, we have 0.1% of hypothyroidism recorded. I'm just trying to scan what has been done in Africa for us to say that it's not that we don't have these problems, only we are not looking at them. Also, albinism in Tanzania is estimated to be around 1 in 1,000. Oh, sorry. Okay. In South Africa, we have prevalence 1 in 1,000 found among the. Also in Nigeria, Igbo-speaking people, we have 1 in 3,000, and in Lagos as well. In population in Southeast England, a median prevalence of phenylketonuria of 0.2%. I can't say that properly. Also, Minnesota, and I've jumped to another country now, continent. So I'm just giving an example of this way these conditions present. If you look at this infant with propionic acidemia, acutely 20 days of age in coma with blood ammonia of 450 micromole per liter and no ketoacidosis. A brother had died 40 days earlier after a clinical similar presentation. Also, another one with methylmalonyl-CoA mutase deficiency, who also failed to gain weight and height and head circumference, and was investigated to find out that it's inborn error. Another one is this Arabian girl with butinidase deficiency. She lost all scalp hair and eyebrows at 20 days, but it returned. So in addition, she had dermatitis about the eyes and hemorrhage and cracking lips. Conclusion: inborn errors of metabolism contribute no matter how little to under 5 mortality and morbidity. Functional national newborn screening program lead to a significant reduction in under 5 morbidity and mortality on the continent through early detection and affect newborns and prompt management. The challenges militating against implementation of newborn screening program can overcome through advocacy, integration of national newborn screening program into national health system, and involvement of government organization. I'm happy Danny actually mentioned that they're also looking into government involvement, but they need to emphasize it more, because no matter how much you do local work, it will not do the purpose I want it to be, because we want to make it a national, that every child has the chance of benefiting from whatever program you implement. Thank you very much for listening. Over to you, Professor Erasmus.
Thank you very much, Prof. Okeshina, for that presentation, and also for keeping to time. So I'm very impressed that the 3 speakers have actually kept to time, and we are really within the time allocated. So please remember that we will entertain questions at the end of this webinar, and hopefully we should be finished in the next 40 minutes or so. So hopefully we will be able to reconnect with Prof. John Aneto from Nigeria as well. He is based in chemical pathology at the University of Ibadan, where I also spent quite a lot of my time. Can I now ask Prof. Aneto if he's ready with his presentation? Prof. Aneto
Yes, I am.
is a member of the Africa Federation of Clinical Chemistry Committee on Newborn Screening. He is also a member of the IFCC Newborn Screening Committee as well. So we are really indeed very honored to have him, as well as the other speakers. As Prof. Okeshina mentioned, that he had been involved, and my apologies for I'm sorry, my apologies for that information that he corrected, but I actually was referring not to the IFCC, but to the AFCC, which just formed its own committee.
Yeah, that's true. Okay, I just
So, but thanks, Prof. Okeshina, for correcting me. I know
thank you.
that IFCC has been involved in NBS, but recently we are now taking it really forward. I think from last year is gaining a lot of momentum, and hopefully we can carry that momentum to Africa. And indeed, this is the reason why we are having this webinar. And you can see that there's a lot of work happening on the African continent. So over to you, Prof. Aneto.
Thank you.
I think you can now share your screen. Good morning, we are hearing you.
Okay, can you see my slides?
Not yet.
Can you see my slides now?
Not yet.
Not yet. Not yet.
Okay, I think it's sharing. So good morning, everyone. My apology that I was bounced out of the platform because of a problem of connectivity. I'm very glad to be here today, and I'm happy that this is taking place. It's essentially an awareness program on newborn screening. And I'm happy that area people have spoken before me. This, for me, is essentially an awareness program. Can you see my slides now?
Not yet.
It says you are sharing. You are screen sharing. I'm surprised that it's not. Hello?
Prof. Neto, please go on share screen and pick the correct screen with the slide deck.
Yes, I have.
Click on the file that you want to show. Double click.
There it is.
You can
So we are
see
seeing it now. Yeah,
Okay.
yeah. Just expand it.
Okay.
And go to slideshow.
Slideshow. On the top, about the 1, 2, 3, 4, 5, about 50 icons.
So meeting, that's all I can see. I can't see slideshow.
No, it's there on the top there, the first line.
Video, audio,
No, not there.
Share,
Come down.
pause, show meeting. That's all I can see.
You can see auto, it's off. Auto save and then come down. Come down. Bring your arrow down. It's off again.
I can just see share, but it's not showing slideshow.
Click on your slide again. Double click your that it's off. It's no more showing. You are there. Yes, click it. Then come to you are going too fast and too high. You just need to look on the come down a bit, one line more down, then on the left. To come to slideshow.
I don't know why it's not showing slideshow. I mean, all I can see is share.
Okay, maybe scroll it and let's see maybe to change, because we are seeing one quarter about half of your slides. We are not seeing the whole slide. Why not get full screen for the presentation? Maybe that will solve the problem.
Can you see it now?
We can see it, but it's not showing fully.
Right.
Slideshow is on top, not below, I think. Oh, it's not even. Know. It's not motion.
All I can see is show meeting. I don't know. I don't know why it's not showing slideshow. It needs to show it.
Maybe the.
Oh, okay. Let's then move on to the next speaker whilst Prof. Neto is trying to sort out. Can I now invite Dr. Bouchid from Morocco, and he is based with the Ministry of Health that is focusing on maternal and child.
Can you see my slide? Can you see my slide now?
Oh, okay. All right.
Yeah, we can see it. So you can just go on.
Okay.
I'm sorry. So, yes, good morning, everyone. I don't know why this technical problem today.
It's okay.
My own presentation is exalting newborn screening in West Africa, building on the pioneering legacy of Robert Guthrie. It's essentially to raise awareness, and I'm happy that earlier speakers have addressed this. So I'll just move on. The outline of my presentation is a brief introduction to newborn screening. We look at what the person we call the father of newborn screening, of inborn errors of metabolism, Archibald Garrod. Then we look at the origin of newborn screening. Then we look at the contribution of Robert Guthrie, whose legacy we are remembering today, and it's a way of raising awareness all over the world. Then we look at the benefits of newborn screening. We look briefly at the situation in West Africa where not much has taken place, then actionable pathways, conclusion, and recommendation. So by way, I do not have any conflict. I said that has been said, I am involved in a number of committees associated with newborn screening, something that I take very seriously. Many people have said this. The inborn errors of metabolism are essentially genetic problems. They arise from mutation or missing genes that lead to missing enzymes that affect a number of pathways. This is just trying to show how this evolved and how this affects the manifestation of the disorders. A number of people, I don't have more time. Archibald Garrod, who is known as the father of inborn errors of metabolism, gained prominence because a very vigilant mother noticed that each time the daughter diaper was removed, there was a dark spot. The disease was not known for a long time. Eventually, it was known that it's acaphonuria, and the missing enzyme was methyltic acid and all that. And that was the beginning of involvement in inborn errors of metabolism. Again, this is just the pathway, because I thought that this was an opportunity to introduce the subject broadly to people. The most famous is phenylketonuria, and this essentially illustrates how this goes on. So there are individual conditions that many people consider as rare, and because of that, they think that it's not important. It is important, and I'm happy that Tumelo illustrated the classical case of an individual that was not screened for congenital hypothyroidism in the Philippines, and what happened with one that was screened, and the complete different outcome and the irreversible damage that was done to the child. So the fact that the disorders are rare doesn't mean that they are not important. And as I will be saying later, you find that in Africa, West Africa in particular, you have a number of homes for people with handicap, intellectual subnormality, and so on. Largely, they arise from absence of newborn screening on the in the sub-region. So these are some of the conditions that you will look at that will raise your index of suspicion. This has been addressed. Now coming to Robert Guthrie, who we remember today and is celebrated worldwide for introducing the first screening test for newborn errors of metabolism using phenylketonuria. This started in 1961 and is now universally practiced in most of the advanced world. But in the low and medium income countries, including Africa, nothing is done. So today I'm happy that we are having this program to raise awareness on the subcontinent. Now, the evolution of technology, because many people complain about technology. You can see how it started, ferric chloride, papers to thin layer chromatography, then spectrophotography. These are things that people have done. So we can also start. So newborn screening is a public scientific activity, which, as I said, was pioneered by Robert Guthrie. It is not like any other test. As was shown with the congenital hypothyroidism in the Philippines, it is a life-transforming process. It is based on public health principles. And of course, like I said, in Nigeria, which is a major country in West Africa and the whole of West Africa, nothing is being done at the moment. So we can then ask ourselves, what are some of the benefits of both? This has been partially addressed. Early detection and treatment of the condition will reverse the number of damage. Then, of course, early detection and intervention will lower morbidity and mortality and related disability. Then, of course, we have to think of affordable technology. Many people say, oh, we are not using mass spec, and that's why we are not screening for some of these disorders in many low and medium income countries, including West Africa. As I was expanding on later, the recent resolution by the World Health Assembly 77 on universal newborn screening is something that should uplift or exalt the practice of newborn screening in West Africa. So again, how did Robert Guthrie come about this? Because I think that West Africa should try to follow the footsteps. He was challenged. His son and his niece suffered from inborn error of metabolism. The niece suffered from phenylketonuria. This was why he felt challenged. So in West Africa, we should also feel challenged with the burden of the problem. I know we focus mainly on sickle cell disease, but just like Robert Guthrie, we have to be challenged to look at this problem and what can we do. Luckily, in most of the advanced countries now, there are platforms and pathways, so we can build on this. So we can at least start by imitating the footsteps of Robert Guthrie. We all know that sickle cell disease is a major condition in West Africa. But we are saying that some other conditions should be added to this when we try to screen, particularly congenital hypothyroidism. Now, this has been mentioned how Robert Kluge introduced the inhibitory test using a bacillus and all that, so I won't go into that. And that is why today we celebrate him on an annual basis, International Neonatal Newborn Screening Day. So let us quickly look at how this evolved in some developing countries using United Kingdom and the United States of America. You can see they started with urine phenistic, essentially based on ferric chloride. Then conferences were organized. Later in the UK, they opened the registrar. The Medical Research Council established a register and a director. Then from urine, they move on to the blood-based test, which was essentially introduced in Buffalo by Robert Guthrie. So we can also start something in West Africa. This is essentially showing the screening market, which shows what is happening all over the world. And you can see that the low and middle income countries, where West Africa lies, is one of the areas where we have very low screening. So this awareness hopefully will lead us to start and probably improve on the condition. Of course, mortality rate from inborn errors of metabolism is very high, and it's highest in the low and medium income countries. And it is said that this accounts for about 0.4% of all cause mortality. And of course, West Africa has its own fair share of this. Now, this is something I consider very important for today's discussion. The 77th World Health Assembly Resolution on Management of New Birth Defects, including inborn errors of metabolism. You know, this is something that West Africa should take very seriously, because many of the participants who proposed this are from West Africa, Nigeria, Togo, West Africa, Gambia, and so on. And low and medium income countries were actually the overwhelming number of countries that proposed this. So this is something we should use when we are asking for legislation in West Africa. We are committed to this. Now let us move forward. So coming to the predominant genetic disease in West Africa, many people have spoken about this, sickle cell disease. Now in Africa, there is screening in some selected countries. In West Africa specifically, we have Ghana, we have Nigeria, then we have Liberia. But this is being done by the Consortium for Newborn Screening in Africa, which is essentially driven by the American Society of Hematology. With the pronouncement of the World Health Assembly, I think West African countries should this, collaborate with CONSA and ASH and see how to expand this and bring in many more conditions, probably starting with congenital hypothyroidism. Now, in Nigeria, we have taken some steps forward. We have formed the Newborn Screening Consortium of Nigeria, which has organized a number of activities. Specifically, in June last year, we commemorated the Newborn Screening Day on the 28th. Then, of course, we have had a workshop in Lagos, a 2-day workshop, which aroused a lot of awareness. Then, of course, also in June this year, we had early this year, we had a workshop here in Abuja where we looked at a newborn screening and how to start off. But Nigeria is starting off with sickle cell disease and congenital hypothyroidism using the oldest teaching hospital in Nigeria, the University College Hospital, as the starting point. And we hope that this will be the hub for West Africa for newborn screening. We are very hopeful about this, and a lot of activities are underway. Now, this map shows membership of International Society for Newborn Screening. Why I brought in this is that many West African countries just take advantage of membership of this and then collaborate. And of course, that will raise the uplift newborn screening in West Africa. There are a few people who are members. I'm a member. I know a few in UCH and some other West African countries. This is also a way of uplifting or elevating newborn screening by interacting with many countries who are here and have already established universal newborn screening in their own countries. So partnership is greatly needed in West Africa, where not much has been done. So drivers of the established newborn screening in the developed world, mostly in the North, must collaborate with us, but we in West Africa must extend our own hand so that they can grab that. Now, many people, when they talk of challenges, talk about technology. I just listed this one here to show how you can do targeted investigation of newborn screening. But when it comes to, oh, tandem mass care, it's expensive and all that, but you can also use a high-performance liquid chromatography or electric focus. Or to do nothing because of technology, I don't think it's acceptable. Let us start and build up. Later, I will be talking about what happened in the Philippines, which has now become a global center for newborn screening in the world. Padilla, who is driving that, started with just 2, and today they are screening for 19. So in 2022, we wrote this publication to raise awareness largely, the pragmatic approach we can, and that's what I just addressed, that we can use basic facilities to at least start something and gradually build up. And when people see that you have started something, they can then come to partner with you. Well, nobody is here from Uganda now, but in the newborn screening worldview meeting that was held last year in Finland, Uganda was a star as the only country that was moving in the right direction. I think West Africa can also learn the lead from here. And the fellow who represented Uganda at that meeting told us how they started. You know, start with what you have. Begin with basics, and then you can then move on to using drive. It's not being promoted as a way of for mass newborn screening. So in West Africa, as I mentioned before, the predominant inborn error of metabolism is hemoglobinopathy, which is known to have a prevalence of about 20 to 30%, especially in countries like the Cameroon, Ghana, and Nigeria. In fact, Nigeria is said to be about 25%. So current effort, as I mentioned, in West Africa is on sickle cell disease, but this must be expanded. And again, like I mentioned, we can copy what has happened in the Philippines. So screening methods, many people say, oh, tandem mass spray, MSMA is expensive and all that, but we can start big and gradually build up to use mass spec. So start small. This was exactly what Robert Guthrie did. And today the whole world has embraced the concept he started in a very small way. So what are the benefits of International Newborn Screening Day? Of course, it raises awareness, and I'm happy if that's all we've been able to achieve today. I think it is something. And I will admonish all of us to stick to it, ensure that in our own very country, in our different countries, not just on the continent, we hold this activity every year. We should invite health policy makers, you know, and challenge them, because they were party to the World Health Assembly number 77 resolution. This is a way to prick them and remind them of their commitment, and this will be a way of ensuring that newborn screening is exalted in West Africa. So this I have addressed the World Health Assembly. This should be a game changer for us in West Africa, and it's something we should take very seriously. There was a study sometime bringing many people together in Africa, led by Terrell. This was in 2019, and many of the players are still on. And this was emphasized in the Sickle Cell Congress that took place in Abuja, 5th to 6th of June, just a few weeks back in Abuja here. So we should build on this. West Africa should also seize the bull by the horn and move on. But of course, this is just showing some of the countries, some of the prominent countries that proposed this: Gambia, Nigeria, Togo, and so on. We should do this. So just like I mentioned, Padilla is a wonderful individual. She is the person driving newborn screening in the Philippines. And she keeps telling me, if the Philippines can do it, at that time we were talking about Nigeria, Nigeria can also do it. So if Philippines can do it, I will say that West Africa can do it. And therefore, we must start today like the Philippines did and gradually expand. So by way of summary, the inherited metabolic disorders represent a significant cause of morbidity and mortality among globally, and also in our program in West Africa, of course, is crucial for early detection and intervention, and especially for sickle cell disease. But we must expand this. We shouldn't just leave it with sickle cell disease, with phenylketonuria, galactosemia, D6PD disease, cystic fibrosis, and what have you. And as has been said, the African Federation of Clinical Chemistry Committee on Newborn Screening is going to conduct a survey to know which conditions are more prevalent in some areas, and therefore work on it. So policy on newborn screening is the most important need for inborn errors of metabolism. To understand the prevalence and the proper health system planning, technology should be secondary, because we always give technology as excuse. So appropriate policy based on affordable technology is important. Then, of course, education or genetic counseling, I'm happy somebody mentioned it, is needed in many low and medium income countries, of course, including West Africa. So West Africa should build on the pioneering legacy of Robert Good Care, aided by the World Health Assembly Resolution number 77. This, for me, should be a great enabler in West Africa. And with that, we ensure healthy lives and promote well-being for all ages, particularly the younger ones in West Africa. So by way of recommendation, the inborn errors of metabolism are rare disorders, and let us not be mistaken for saying because they are rare, they are not important. They are collectively important. It's a newborn screening is a scientific and public health priority that increases quality of life, not just like any other test. So genetic counseling to be established in all health facilities in West Africa. Of course, collaboration, partnership, and networking with the advanced countries with established systems will be beneficial to us in West Africa. Although the current focus is on sickle cell disease, this should be expanded to include congenital hypothyroidism for the start. And of course, legacy of Good Care, and for me, it's a great inspiration. Celebrating International Neonatal Newborn Screening Day. This should be institutionalized in West Africa. Very important. The World Health Assembly So I thank you. There's so much noise. I thank you for giving me the opportunity to make this presentation. I apologize for the hiccups that I had at the beginning. The consortium in Nigeria, which is going to serve as the hub for West Africa. I thank all the key participants, Ayede, Rumadegu, Ugiogwa, including Professor Occasional. So great appreciation to Revit that has driven a number of the activities in Nigeria and West Africa, because I know sometime last year they had a laboratory training workshop in Ghana. So I thank you for listening, and I'm prepared to take some comments that you may have. Thank you for listening.
Thank you very much, Prof. Aneto. I am really, really motivated that indeed this AFCC committee on newborn screening, which is a relatively new committee, is so passionate about taking newborn screening in Africa forward. So you can actually see the passion coming out in all the speakers who have talked on this very important condition in newborns. So I will now go on to, just to remind ourselves that the questions will come at the end of this webinar. So we will now quickly go on to the last speaker, who is Dr. Bouzid from Morocco. He is based with the Ministry of Health in Morocco, that is focused on maternal and child health. So there is Dr. Azdeen Bouzid. Welcome, Dr. Bouzid, to this webinar. We are really, really very thankful to you for participating. And Dr. Bouzid was recommended by Dr. Hakima, who is a member of the AFCC Newborn Screening Committee. So over to you, Dr. Buzid. I see that I gave the wrong ministry. It's the Ministry of Health and Social Protection Population Directorate. My apologies for that, Dr. Buzid. So over to you, Dr. Buzid. Hello, Dr. Buzid. Please go ahead. I think we are having some connectivity issues, but I see that I can see his presentation. Dr. Buzid?
Yes, I'm with you.
Okay.
He's working on it, I'm sure.
Okay, please go ahead.
Are you listening?
Yes.
Yes, we can hear you.
Thank you so much. So
yes, we can hear you.
I thank you for the invitation. It's a pleasure to participate with you in this great day for this important issue, the newborn screening, of course. So I'm honored to participate with you, the Moroccan experience in newborn screening. I will go with the with this outline. So we will start with an introduction and background, general information on newborn screening, clinical newborn screening, biological neonatal screening, and of course, perspectives. So in introduction, Morocco has made significant progress in improving maternal and newborn health and continues its commitment to the positive progress of national indicators within the framework of the Sustainable Development Goals. Currently, the advent of the overhaul of the health system as stipulated by Framework Law 06/22 is a historic opportunity to establish a resilient health system able to provide an expanded package of quality services with equal and equitable access for each segment of the population in accordance with our Constitution, in particular through new governance and the strengthening of healthcare provision. Screening for the most common congenital diseases is one of the actions taken to combat infant mortality and morbidity. It's a public health initiative that aims to systematically screen all newborns for early onset congenital pathologies before they cause irreversible damage. Indeed, the Ministry of Health and Social Protection has committed to an integrated policy of prevention and health promotion, making the generalization of early screening at birth, as well as the management of certain diseases in newborns among the essential components of its strategic orientation. So the context, the international level is, of course, the Sustainable Development Goals targets, the Global Strategy for Women's, Children's, and Adolescents' Health 2016-2030, the Arab Multi-Sectorial Strategy for Maternal, Child, and Adolescent Girls' Health 2019-2030, and of course, the Plan Maputo 2063. The national level, of course, we have the Constitution 2011, which is the right of health. Morocco's commitments to the Sustainable Development Goals by 2030, the new development model health commitments in the 2021-2026 government program, the Framework Law 06/22, and the National Strategy for the Elimination of Preventable Maternal and Neonatal Deaths 2025-2030. The congenital anomalies, as you know, every year, 240,000 newborns die before the age of 28 days due to congenital anomalies. 9 of 10 newborns with a serious congenital disorder are found in low and middle-income countries. Congenital anomalies can cause long-term disability with significant social and economic repercussion. So the importance of prevention, which is based on vaccination or immunization, adequate prenatal care, early detection, and adequate administration of folic acid or iodine through fortification or staple foods or providing of food supplements. The objective of the neonatal screening is, of course, to contribute of the reduction of neonatal mortality and morbidity, then reduce the prevalence of mental disability linked to the neonatal period, and expand the provision of neonatology care to cover screening for congenital metabolic disease. The complement newborn screening is the training, the information, education, and sensibilization, of course, the screening, the diagnosis and the treatment, then the management and the coordination, and of course, monitoring and evaluation. And this is a cycle. The implementation of new national program newborn screening, we started with pilot phase, short-term, preparatory phase of launch, execution, monitoring and evaluation, acquisition of field experience, and mastery of the principles of base and organization. Then the phase of extension, this was in medium term, extension to the whole delivery facilities at the level of the pilot region and extension to new regions, and of course monitoring and evaluation. And then the generalization phase on the long term, development of schedule from maternal, regular monitoring and evaluation. It was a dynamic and evolving process. The types of newborn screening in Morocco is clinical screening, biological screening, and neurosensory screening. The clinical screening, of course, has as target the 15 diseases that you know, and we focused on the first one, the neural tube closure defects. The biological screening in Morocco, we had laid the first foundation for early detection of anomalies in newborn through the progress implementation since 2012 of neonatal screening for congenital hypothyroidism. Why hypothyroidism congenital? As you know, the Wilson and Gengner criteria, the congenital hypothyroidism respond perfectly, meets these criteria. So the most common endocrine disease, its frequency is between 1 per 3,500 and 1 per 4,000 births in the majority of countries that have established a systematic neonatal screening program. In Morocco, during the period 1996 and 23, some local studies have been conducted by the Ministry of Health in collaboration with scientific researchers laboratories in Rabat, Casablanca, and Fez, and have shown that congenital hypothyroidism affects approximately 1 of 2,000 live births. So the history of the implementation of neonatal screening for congenital hypothyroidism in 2012-2014, the launch of the pilot phase in the Rabat Saleh Zemmour region, and in 2015-2019, the launch of the screening at the Fez Meknes region level, Marrakesh Safi, and Casa Stad, and Beni Mellal Khenifra. In 2020, decentralization of credits allocated to the purchase of screening reagent to the regions concerned, and 2022-2023, the launch of the screening in another regions, Dar'at Filaj and the Oriental. Now we have generalized the screening of hypothyroidism in 12 regions in Morocco. We have an information system, national guidelines, and many publications after more than 10 years of experiences of screening. About management organization, it starts with the family and the parents, then with the health center and the delivery facilities, and it's managed by laboratory, regional laboratory, many committees, the regional one, the technical committee, and of course, the director committee in the ministry at central level. About perspectives, we have already generalized the neonatal screening for congenital hypothyroidism and deafness in all regions of Morocco. And now we had to extension the neonatal screening to other pathologies, especially phenylketonuria, congenital adrenal hyperplasia, cystic fibrosis, and sickle cell disease. The phenylketonuria is a disorder of amino acid metabolism. It's an inherited genetic disease that prevents affected children from assimilating or metabolizing a naturally occurring substance in the diet, phenylalanine. Its primary cause its deficiency in phenylalanine hydroxylase. So the PKU in figures worldwide, an estimated of 500,000 people suffer from PKU with global prevalence of 1 of 24,000 live births. The prevalence of phenylketonuria at birth varies across regions of the world and is estimated to be 1 of 4,500 newborn affected. Geographically, it's generally lowest in Asian countries, with the exception of China, and highest in European and Middle East countries. The disease affects both girls and boys equally. The phenylketonuria screening, a specific test, of course, the Guthrie test, is carried out using a few drops of blood at the 3rd day of birth on blotting paper to check the phenylalanine level in the newborn. The diagnosis is based on the detection of high phenylalanine level and the normal or low tyrosine level. The treatment, lifelong dietary restriction of phenylalanine. The prognosis is excellent with treatment. This involves following a low protein diet, low in phenylalanine. This should begin on day 10 and continue throughout life, although it is less strict in adults than in children. Until age 11, the goal of the diet is to maintain serum phenylalanine levels between 2 and 5 milligrams at all times to allow for normal development. Then gradually metabolic control can be relaxed with a more normal diet and serum phenylalanine levels below 20 milligrams in adulthood. The diet should be repeated during pregnancy to avoid embryo fetal. Reflection on feasibility of implementing the phenylketonuria in Morocco. So it's responds perfectly to Wilson and Degner criteria, except 2. The effective treatment can be administered to subjects in whom the disease has been detected. And the second criteria is the cost of detecting cases, including the cost of diagnosing and treating those found to be ill, must not be disproportionate to other costs of medical care. Our challenges now is the availability of treatment and, of course, the reimbursement by health insurance. To implement the phenylketonuria in Morocco, we will do it this year, 2025. All what we need, of course, is access to amino acid, purchasing low protein products, and our challenges, our limits was the products not available on the Moroccan market, expensive products, and compliance with the diet. Now, recently, we are exploring some new routes, especially with the private sector and some laboratories working with new technologies as a rapid screening test. The product of treatment of phenylketonuria, we will have it in our market in 3 or 4 months, and the rapid screening tests are available. So we will start to screening the phenylketonuria in 3 or 4 months this year, 2025. This is what I have to share with you about our experience, and I thank you so much for your attention. Thank you so much.
Thank you so much, Dr. Bouzid, for that excellent talk telling us about what is happening in Morocco. So I think we have come to the end of this webinar, and you would all appreciate that this has been a great presentation from the various speakers, and each one of them have actually focused on different areas of newborn screening as it impacts on Africa. So we still have a few minutes left, and therefore this is an opportunity for us to welcome questions. And I see that Prof. Pillay has also joined in. Prof. Pillay, welcome to this webinar. Prof. Pillay is one of the leading people in South Africa with a great interest on inborn errors of metabolism. So I will now put the floor open for questions to the panel. Over to the delegates now to put forward their questions. If you want, you can put them out in the chat box. So we are waiting for questions from the
Terry has raised his hand. Terry wants to speak.
Okay, please go ahead.
Today's hand is up.
Thanks. Thank you. Yeah, thank you for your welcome. I wanted to say that this is a great session, great initiative, and I was thinking that I was just messaging to Mello, Dr. Sateche, to advise that he considered doing another session like this and with case presentations. So something like a grand round, IMD grand round, maybe for the same duration of time. I don't know what you guys think of it. I think that's something we should do. I think case presentations are always good, and I'm sure all of you guys have very interesting cases to present. More specifically, I was interested that Morocco is still doing a Guthrie test, and I'll be curious to know if anybody else still does a Guthrie test in other institutions in Africa. Thank you.
Morocco is planning. They are proposing it, not that they've started.
Oh, I see. Thanks.
Okay, so thank you very much, Tahir, for that input. I think Tumelo is certainly going to look into this as the secretary of the AFCC NBS committee. As you know, this committee is expanding, and recently we have a member from Kenya joining us, and we would, of course, welcome other African countries to join this committee. Because the IFCC is really pushing NBS on the global agenda. So certainly, I think Tumelo, please look into this and liaise with Prof. Pillay and the rest of the team in Africa. So let's not just make it a South African affair. but in fact make it an African affair so that we can get everybody on board. And indeed, this will create further awareness. And if possible, maybe we should get somebody from the various ministries from each of these African countries. So I think that should be one of the areas that we should look into. So I'm very glad that we have someone from Morocco, from the ministry, because as you know, they are the ones that are the drivers of the policy, and they are the ones who arrange the funding and in fact the modus operandi of all these operations. So I think we need to get them on board. If you actually look at the IFCC committee, when they were trying to promote NBS in the developing countries, they had some successes in the Dominican Republic, and what they said was that you need to get the ministries and the ministries of health involved at a very, very early stage, so that all the stakeholders that are critical are aware of this issue and we get them on board. So IFCC is not taking over their role, but is actually complementing and providing any help that they can. As you know, IFCC also has 60 corporate members. So we are in a unique position to help newborn screening in the African continent. So any more questions before we wrap up?
My hand is up.
Please go ahead.
Hello? Yes, thank you. I appreciate Professor Pile's comment, but I just wanted us to be careful because I don't know what the presenter from Morocco has to say about this. I think when we tell them, I know that the Gottfried test is considered primitive now, but I think what we should appreciate is the spirit, at least for having that initiative to start. Then we encourage them to expand and embrace current technology, because if others say, oh, if we are still using outdated methods or technology, but let them start, just like a Cadillac would say. We have started from a basic point, it is easy to expand. Thank you.
Thank you very much, Prof. Aneto. Tahir, do you have any comments on that?
No, just before the Erasmus, I think I support Nectar's view. Start somewhere. Start what you have. Use it and move on. Otherwise, you will not start at all. You will not do anything. So that's what the spirit of this, what we are trying to advocate now. Thank you.
Thank you, Kunle, for that comment. Are there any other comments? Tahir, do you have any other comment to make?
No, just going to say that I was just asking out of curiosity when I asked about the Guthrie test, and I agree. Every journey begins with a single step, so one has to start somewhere. And so, so that was, I was just curious. It was more out of curiosity than anything else. Thanks.
Thank you. Dr. Buzid, you have any comments to make?
Yes, I thank you all for this events. I hope it will be repeatedly every year. I'm a representative of the Ministry of Health. I am head of maternal and newborn health protection, and I explain my engagement with you to boost the newborn screening. We should start with yes, of course, we are now screening 2 pathologies, and of course we will expand that and extend it to 5 pathologies at least from now to 2030. And I repeat my engagement with you to implement and the newborn screening in Africa. We start with what we have, and it's just the beginning. It's just the beginning. Thank you for this opportunity. Thank you so much.
Thank you, Dr. Buzit. Tumelo, if you are still there, do you have any responses to some of the comments that have been made? Oh, there is Tumelo.
Yeah. Yes, thank you, Prof. Rasmus. Sorry, I got disconnected. Yes, first of all, I just want to respond to Prof. Pile's suggestion of presenting cases. I think it will really be a good opportunity to do that, as to raise awareness of inborn errors metabolism as well. And the problem is that it will be unfortunate that we'll be presenting late diagnosis complications because these patients wouldn't have undergone any newborn screening, which is quite unfortunate. But I think this way will be raising awareness for both inborn errors of metabolism and why we should be considering newborn screening for these conditions. And from our side, I think the most important thing is the public and private partnership, because we do have quite a lab with best state-of-the-art, equipment, tender mass spec, but it's only serving a very, very small percentage in the private sector. So if you can have this partnership with them, serving the wider community with regards to comprehensive newborn screening, will really get somewhere. So yeah, we'll work on the case series, case presentation for the next presentation. Thank you.
And so I just see Professor Krin from Slovenia. He is very much interested in inborn errors and newborn screening. In fact, he will be speaking at the Kenyan Association of Clinical Pathologists. I've actually invited him to speak there in Mombasa in October. Prof. Krin is the former president of the Slovenian Society of Clinical Chemistry. Blas, do you have anything to comment?
Hello, do you hear me?
Yes.
Okay. Really
Yes.
great to meet you all. So it's interesting, to hear that in Africa the newborn screening started and it's developing. So we started in Slovenia with phenylketonuria and congenital hypothyroidism about 45 years ago. And it will be so, just as already told, so just start with the small steps and then you go with further. So as we perform screening for several years, which is just ELISA test and fluorimetric tests, and in 2017, we moved to mass spectrometry and so on. So for now, we were screening for 41 diseases, but will be very interesting to share our experience in Mombasa, and so I'm very excited to hear that the screening tests are developing more quickly now in Africa.
Thank you very much, Prof. Krin. So Tumelo, this is an opportunity for you to please get in touch with Prof. Krin. I think this will really expand our network, and really we welcome our colleagues from Europe, because AFCC is very much linked with the EFLM, and they have actually promised to help us. And this is an area that we can actually engage with our colleagues in Europe, as well as the Arab Federation. So I will try and see if we can get some people involved from the Arab Federation. Maybe Dr. Buzit can help us to identify some people, particularly in Lebanon or Syria, Egypt, and so on. So I think really we need to work together. Just 3 days ago, I was in Egypt, and we are actually trying to bring the African continent together to address some of the health issues that are facing Africa. So I think I would just want to close off by asking Prof. Aneto just to say some comments, and then we will wrap up with Prof. Okeshina, who is the chair of this committee, to give us his final comments. So just 30 seconds, Prof. Aneto.
Okay, well, thank you very much. I must say that I'm very excited that these are taking place. Like we said, this is the beginning of great things to happen in newborn screening in Africa. And we must thank Professor Erasmus, Professor Okechukwu for the drive. And we hope that all our colleagues will continue to partner with us. Thank you very much for attending this session. Thank you.
Okay. So, Prof. Okeshina, we will like to end with your final comments as the chair of this committee.
Yeah, thank you, Professor Erasmus, and everybody. I want to just appreciate everyone for the successful arts outing we have had, and also to promise that it's going to be an annual event. You know, because like we have said, on many people have mentioned it, they need to move forward, and we'll come back again in a year's time to review what we have achieved, what difference we have made in our various locations, so as to move forward and to be sure we are making progress and encouraging ourselves. We have a lot to share from to enjoy from Morocco, who has actually established and wants to expand, and is an African country, so we can emulate others and then move forward from what they have achieved. I appreciate everyone, and thank you very much, the coordinator, for a successful outing. Thank you.
Thank you very much. I just forgot to ask Dr. Maina to please also give some comments. As you know, he's collaborating with Aga Khan in Karachi, and I think this will be a good way to really also involve them in helping Africa going forward. And as you know, John is also very much in touch with them because the co-chair of the IFCC NBS committee actually comes, I think, from Aga Khan in Karachi. So really, we are bringing everybody together, you know, West Africa, East Africa, South Africa, the Arab Federation, North Africa, and now we are also including Aga Khan in Pakistan, in Karachi, through their network in Nairobi. So if Dr. Daniel is still there, Daniel, are you still there? I see he's still there, but maybe hello, Daniel, are you still there?
He's still there. He's there. He's muted.
Okay. All right, so just to thank all the delegates, all the participants for listening to this webinar. I also want to thank all the speakers for keeping to their time. This was supposed to be 2 hours, and I think we have just, we just exceeded by 4 minutes. So well done to all the speakers, and very interesting conversations we had there. And I think we are going to push this thing forward. I'm really motivated. And just to let you know that I'm now on the board of the Foundation for Emerging Nations, and we will be supporting very strongly the newborn screening program in Africa. I think they are writing up a short proposal. We have already asked the committee to allocate some money to do an economic study, which Dr. Tumelo will be leading in South Africa, and hopefully that the results of that study will inform further and future programs on the African continent. So once again, thank you very much and take care. Bye then.
Thank you so much. Thank you so much.
Bye, everyone.
Bye, everyone. Thank you so much.
Okay, bye.
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 Bye-bye. Aneto, how are you?
Fine, thank you. And you? Well done.
Okay.
Well
Have a
done.
nice
Thank
day.
you. Yeah, same to you. Thank you.
Okay,
Okay,
Tumelo.
then,
Bye-bye. Erasmus.
Bye.
Okay.
Bye
Good
to
outing. Thank
Bye,
everybody.
everyone. Bye. Bye.
Bye-bye to everyone.
Bye, everyone.